Zelos Podcast is sponsored by Kinetic IQ, where intelligence meets motion. Kinetic IQ brings a biomechanics lab into the palm of your hand, letting you measure movement anytime, anywhere, with just an iPad or an iPhone, and no wearables required. I've been using Kinetic IQ's markerless motion capture in my own practice, and whether you're screening athletes, analyzing posture and gait mechanics, optimizing performance, or guiding return to play, it helps practitioners like us save time, capture more objective data, and make instant actionable decisions. So to learn more about how Kinetic IQ is shaping the future of intelligent movement, visit them at kineticiq.com. That's KINETIKIQ.com. You know, I can't tell you how thrilled I am to have Metabolic Elite be one of the sponsors of the Zelos Podcast. You know what makes Metabolic Elite different is their commitment to real results. I've seen a lot of supplements and performance enhancement things over the years, but they pair clinical experience with innovation, like Lipitab, their proprietary solid-state liposomal delivery system. It's a chewable format which enhances absorption like nutrients like BPC 157 and synapses. They're delivered more efficiently in the body, supporting recovery, focus, cognitive health. Their formulas go beyond the basics, solving performance health challenges at the system level. Every product is tested for quality, it's backed by research, and trusted by athletes and clinicians alike. So learn more at metabolicelite.co. And you can get 10% off all of Metabolic Elite products by entering the coupon code ZELOS, ZELOS. Thanks for tuning in to the Zelos Podcast, the show that's all about the pros behind the pros in sports. I'm your host, Rocky Snyder. This week, Tom Swales is with me. He is a physiotherapist, athletic trainer, and a whole lot more. We got to meet at the Fascist Seminar back in March in Fair Lawn, New Jersey. And the work that he's doing with advanced movement therapy is something we're going to dive into. But we still have a little bit of time before that begins. Remember, we've got one more summit. Providence, Perform Better, August 20th to the 22nd. You may see me there. And at the end of this month, I want to invite everybody to a free webinar that Bobby Aldridge and I are doing through Perform Better. It's called Metrics and Mobility. It's a practical framework for assessing and tracking mobility. Completely free. If you're interested, just go to performbetter.com. Check out my website. I won't go into it, but if you haven't been to rockysnyder.com, please visit it by now. And drop me a line or a review in Instagram at Rocky_Snyder. Click the subscribe button and enjoy the conversation. Tom, turnaround's fair play. I was on your podcast not too long ago, and I just felt like, man, we got to continue this conversation, but do it in my house now. So first of all, welcome to the Zelos Podcast.
Thanks for having me, Rocky.
It's a pleasure, man. It was great to connect with you this past March at the Fascist Summit in Fair Lawn, New Jersey. That was such a great event. But man, I just want to dive right into it, really. I mean, you developed the advanced movement therapy.
Yes.
And let's just jump right into what is advanced movement therapy. Maybe give a little background of yourself, real brief, because you could go on judging at the number of certificates on the two shelves behind you that are about to buckle under the weight. Just give us a brief background and jump right into advanced movement therapy, if you don't mind.
Yeah. So coming from AT background, PT background, graduating school, I realized one thing: we don't know much, which is fine. School gives us a foundation of knowledge to build upon. And I wanted to be really good really quickly. So what did I do? I started just learning more skills. Started doing my advanced manual therapy certification, took acupuncture, did some osteopathic courses, my RKC, everything under the moon. And everything was great because it would reignite my passion for what I do. But then everybody got the flavor of the month. Everyone gets acupuncture. Oh, I did a course this weekend. Everyone gets this. So you start applying it to everybody, and it works for some people, but not for everybody. You're like, okay, well, maybe I'll go back and use this tool. And it would work for some people. And, oh, well, this doesn't work. I need to take another course. So over the course of 8, 9, 10 years, I've spent almost 100+ grand of courses and certifications, and I start getting more confused because we come out of school with imposter syndrome, and then we go learn a bunch more stuff, not realize what is actually working. So that reinforces the imposter syndrome. And then you start thinking, well, what the hell works? I have no idea. So then I start looking back. I start looking at the fundamentals of all these different systems, all these different approaches, traditional Chinese medicine, fascial stretch therapy, joint manipulation, kinetic chains, physics, all the stuff. And I started trying to figure out, I'm like, what is the through line? What is the common theme behind all these methods and modalities? And it distilled down into 5 core principles. What makes up the human being? The first part of every assessment, we have a conversation. Okay, what's happening in the conversation? Well, I need to ask that person who's in a vulnerable state, what's going on? What are you missing? What are your injuries? I have to create connection and trust, right? Which then creates safety. So I have to affect their psychology, because a lot of times they're coming in with these beliefs of, well, I have degenerative this, and my doctor said this, and I can never do this again. I'm like, why? Everyone focuses on the dysfunction. I said, okay, yeah, we're not able to do this, but the body's working pretty good over here. So let's focus on the positive. And as soon as we start shifting their mindset into what they can do, all of a sudden their nervous system starts to relax and they start to move better. I'm like, okay, well, what's happening there? Well, I got to now affect their nervous system. So making that shift with words and creating safety in the system, I'm like, okay, well, all of a sudden their pain's gone down and I haven't touched them yet. So what's happening there? How do I measure my effectiveness? And then we start looking at movement. How does the body move as a system? How does the body move individually? Okay, well, now we look at neurology, because muscle testing, movement, that's all outputs. That is just telling us how the nervous system's organizing. And if it feels safe, takes the brakes off. If it doesn't feel safe, puts the brakes on. Okay, so it's a go, no-go system. So that's neurology, right? We do muscle testing, we do nerves testing, we look at cerebellum and the visual stuff, if they've had past concussion. Okay, so that's kind of the communication network in the body. And then we apply manual therapy techniques. And we have all these fancy ways to explain from a mechanistic perspective. Well, when I glide the joint this way in an arthrokinematic fashion, we're improving joint mechanics, proprioception, blah, 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 blah. Okay, well, what are we really doing? We're just changing inputs. When I stick a needle here, we're adding information to the body. And now the nervous system's deciding, does this feel safe? Yes or no? If it feels safe and it accepts it, takes the brakes off. All of a sudden, muscles relax, muscles turn back on. Movement improves. Okay. So now we're affecting the biology through the neurological system. And we're applying stresses to the tissues to create adaptive stress, movement, exercise. I said, well, what else is going on? Well, everything we do is molecular. Our DNA is composed of 5 molecules: hydrogen, carbon, nitrogen, oxygen, and phosphorus. Okay. So there's a chemical component. When we eat food, it's broken down into its molecular structure so that we can use it. Okay, carbon, hydrogen, nitrogen, oxygen, and phosphorus. Cool. When we breathe, it changes our neurology, but it also affects our chemistry, right? Either you're too acidic or too alkaline. So now I start thinking, breaking down, because people always ask, well, what is this doing? And we can come up with these terms that we're taught in school, or we can just break it down into its fundamental principles of understanding.
Don't show off your intelligence. Just make it easier to understand.
Easier, right? Because laser, ultrasound, what are these? They're forms of energy. Mm-hmm. And if we apply the right amount of energy, we're going to cause a stress response, and the body's either going to be affected in a positive way. If it's too much, it can be a destructive way. And if it's not enough, it doesn't do anything. So it helps explain what we do, why we do it, and how we do it better. And then I start looking at injuries. Okay, well, we've got this shoulder injury, we've got this back injury, but you know what? Your hips don't rotate and they don't extend, and you don't have a stable base on the foot, and your core sucks. So all of a sudden you're moving more into those painful areas because they move pretty good. So I'm like, oh, injuries are a physics problem because energy moves to the area of least resistance. So if you have a joint that doesn't move, but you have a spine that moves pretty well, guess where you're moving more into that spine. But then all of a sudden we got an overuse problem. You got an Achilles issue. Well, you didn't take twice as many steps on that side, but you don't have a stable base and you can't extend the hip and your glutes not firing up and you got poor cross core reflex. So guess what you're driving off of? That nice big strong calf, because you're not using anything else around it. So now you're accumulating energy or force into the Achilles and it's breaking down. Now it's an overuse problem. I'm like, no, it's an energy distribution problem. And then it's an energy management problem. And then it becomes an energy accumulation problem. So we call it DAM, distribution, accumulation, management. So you got a DAM tendon problem. So from an injury perspective, you can either have macro or micro. So it's either too much energy in a low dose over a long period of time, or you have a large dose of energy that enter the body that cause tissue destruction in a very short period of time. Regardless, it's an energy problem. So then I start thinking a little deeper. I'm like, well, are we composed of matter, right? What is matter composed of? Well, if you look deeper, okay, it's tissues. And then you look down that, it's cells. You look deeper in that, it's atoms. Now, atoms are composed of 99.9999% empty space. So therefore, we're just a collection of empty space. But how do we perceive matter? Well, Tesla said it. It's vibration, frequency, and energy. So we have molecules, atoms vibrating a specific frequency that we can perceive by the five senses in the three-dimensional world. That's what creates matter. Okay, cool. So if I apply a certain energy to those atoms and they vibrate a specific way, it's going to affect the cells. And the cells are going to help repair tissue. And the tissue can now adapt to the stresses. Now, here's where it comes full circle. What also affects matter? Thought. What are thoughts?
Because it's a vibration.
It's a vibration. Why do most drugs not make it to market? Because of the placebo effect. So psychology is affecting your biology and your neurology and your chemistry, and it's creating the drug that you're missing or the molecule that's missing simply because they believe it. And we can think ourselves into health, but we can also think ourselves into illness. So this is where it comes full circle of understanding the individual human being in front of us through those five principles. Now, I say this and explain it to clinicians. This is for us. This is for us to better explain what we do when we're applying a modality or an exercise or why an injury's happened. And we can explain this a little bit to the clients. Like, hey, this is a physics problem, right? This isn't moving. That's not firing up. And you're driving all this force into here. Okay, that makes sense. But then we take a step back and we start looking at, well, how do we develop in utero, right? Through the three germ layers, endoderm, mesoderm, ectoderm. Well, what composes of that? Okay, well, they're just tubes and wires. And then these tubes and wires expand. And then it creates this whole network of tubes and wires. Now, tubes can be nerves. They can be blood vessels. They can be lymphatics. They are fascia. They're everything. So if you affect one end of a tube, it's going to affect conduction or flow to the other end of the tube. And then you look at Chinese medicine and you look at qi. Well, that's just bioelectrical energy channels that when they're disrupted, body comes out of balance and you get this dis-ease. So using a lot of these different approaches and different lenses, I took it back to first principles to better understand what we do. And then once I did that, I can build more knowledge on top of that because it just started getting too confusing. I'm like, I don't know what works for anybody. But if I systematize this, if I organize how we assess somebody, we have a conversation. I'm going to look at posture. I'm going to look at movement. I'm going to look at the nervous system. I'm going to look at the parts and the pieces. I'm going to look at reflexes. If I can go through this hierarchy of importance, I can very quickly navigate the very complex individual in front of me in a very simplistic way. And it removes a lot of the guesswork of what do I need to treat first. I'm more interested in the appendix surgery you had 20 years ago than the new neck pain right now. Because if that scar is still winding and twisting me and I can't extend and rotate, well, I got to rotate through my neck or someplace else because the body loves the lesion. But if I can release that scar and get that fascia to open up, well, now communication and force distribution is going to be more symmetrical through the body.
So here, I love everything you've just said. I love how you have, you took everything apart and you started from the ground up.
Yep.
And I'm wondering, what is it like in your world with colleagues, with PTs and ATCs, when you begin a conversation of this manner?
I have to go slowly. because not that people cannot understand this. Like I said, we were talking earlier. I almost failed. I almost failed at a physio school because of neuro. I didn't get in the first 2 tries. I actually got into physio school on the top of the shit list. They called me a month before school starts. Hey, we got into a situation. You're on the top of the rejection list. Do you want to come? Yeah, I'll see you in September. Right. So I was never an academic, but because of my extreme curiosity and always trying to ask why am I doing this? Why does this work? Then it forced me to look deeper into first principles. And that's really, the more I listen to experts, everyone talks about first principles, frameworks, and systems, because that's the easiest way to understand something, to build something, and then to apply something. So your first principles is to understand what you do. Your framework is, what do I treat in which order, based on neurology, based on the safety, based on what the brain needs for survival, based on embryology and neurology, like top down, center out. Okay, how did we learn how to move in the 3-dimensional world? Well, babies spend a lot of time developing their spine first before they're allowed to sit and stand and do all the crawling. So I started looking at order of operations. I started looking at hierarchy of importance. And, even from an energetic perspective, what system uses up the most amount of energy and resources? The nervous system. So it's probably pretty damn important. So that's why I'll treat nerves first and the spine first before I treat muscles. Because if I've got somebody's coming, I got a tight pec or lat. If there's nerve tension there, that pec is never going to release because the body's going to protect the nerve. So we better floss that out. We better mobilize that neck. We better get that T-spine moving first, get that central neurodynamics, peripheral neurodynamics. And then, oh, you know what? It was never a tight pec to begin with. It was just nerve tension. But if we just looked at the muscle and started treating the muscle, we're never going to fix the cause. And I like to say to my clients, I'm like, muscles are dumb. They only do what the brain tells them to do. It's either protect, stabilize, or compensate. And if you can understand why that muscle's toned up, then you can actually fix the problem. What is it protecting? What is it stabilizing? What is it compensating for? Is it weakness on the opposite side? Is it nerve tension? Is it a joint restriction that the muscle's trying to fight against? Like, let's look a little bit deeper and keep asking why.
And we boil it down into ultimately the nervous system's own survival. And
Yes.
there is a threat to starvation and a threat to existence, right?
Yes.
And every movement, every system, every, I would say, decision, if I could use that word, it boils back to, or circles back to, those two threats.
Yep.
Would you say?
Yes. So the primary job of the nervous system is survival. That's it, right?
That's it.
It's a go, no-go system. And pain is a threat to survival. Body feels something, ooh, that doesn't feel safe. We should probably protect that. We should avoid that, right? But then it creates compensations. We start to move around that pain because pain changes behavior and movement is behavior. But if someone's just kind of ignoring that and they kind of keep trugging along, which is fine, like that's part of survival. Compensation is good in an immediate, but if we leave that compensation there too long, all of a sudden a new injury or a new pain syndrome pops up someplace else. Well, it's because you're avoiding the right side because you're overloading the left. And the body needed to do that. But all of a sudden it creates a louder signal to pay attention and be like, hey, I have a pain here. I don't know why it's here, but I need you to find out why. And no, it's not. It's often not that damaged tissue's fault. It's because it's trying to pull the load for something else. And once we understand that, and once we start to take a step back and look at the body as a system of systems first, then it gets really clear as to what's that root driver? What's that first linchpin that's driving the system that we need to pull to unravel all the compensations to help the nervous system and body reorganize in a more optimal way.
Okay, so how about this? You're
Yep.
talking history, an individual's history, whether we call it health history or experiential or whatever.
Yep.
And let's just say you don't know an individual's health history.
Yep.
How do you navigate back to the initial insult, the root cause, however you want to label it? How do you roll back the layers of the onion to get to where it all began?
So say we didn't take a history, I'm just going to look at what's their posture like. Because the way I define posture It's a physical representation of the organized inputs from the internal and external environment. What is the
God, I
body
love
feel?
you. I just want to
What
say
is
that
the,
right now.
what is the
I
body
love you.
feeling? Right? It's a snapshot. That's all it is. We
That's
can't
it.
diagnose from that. There's no diagnosis. Someone's got a tilt. You don't know why they're standing like that. They're just, the body's trying to do the best it can. And
Strategy.
it might be avoiding something on one side. It might be leaning in, protecting something else on the other side. I don't know. But then we can look at, well, there's muscle atrophy here. So you start thinking about what nerves innervate that muscle. Okay, there's winging of the scapula. Well, it's serratus anterior, force couple issue. Like we can come up with all kinds of things, but we don't know why. And then once we look at posture and it gives us a guide as to what we might want to look at a little bit deeper. And then we look at, how does the body move as a system? Can you bring your chin to your chest? Yes or no? Any pinch pain pull? Look up towards the ceiling. Are they hitting 10 degrees from parallel? Can they rotate? Okay. Can you bend forward, touch your toes? Can you back bend? Right? Any pinch in the back, any pull in the front? Can you rotate symmetrical? Oh, rotation's a little bit different that way. And I always ask the patient, does one side feel different than the other? Because oftentimes they're like, I don't have pain, but does it feel different? Is it more effort? Yeah, it doesn't feel like I can move that way. Yeah, you're right, because your pelvis isn't coming around with you. So there might be some hip issues. There might be some stability issues. I don't know. So we're taking another layer of, okay, well, here's the static movement. I know that's kind of a contradictory saying, but we're just looking at how they're organized. And then we're looking at how the body moves as a system. Can you stand on one leg? Yes or no? Oh, geez, I can't stand on my left leg. Yeah. And all your pain's in the right knee, isn't it? So if you're running and your brain knows, well, standing on the left leg's not safe. So guess what? You might be doing a little bit more to that right side. You might be hitting the ground a little harder. You might be staying a little bit longer on that right side. When you squat, you're probably shifting to that right, safer side because the brain's like, well, I don't feel safe on the left. So I'm just going to keep overloading the right. And all of a sudden now you got a pinchy meniscus or a pinched low back or an Achilles issue, right? So we look at how the body moves as a system. And then the next part of the algorithm is, I want to see what your nervous system's doing. Let's look at central neurodynamics, slump test, peripheral neurodynamics, straight leg raise. I want to know if the nerves are sliding and gliding. Because if they're not, they're going to create a lot of tightness. And I'm going to use the air quotes, tight, because it's not tight muscles. Those are muscles protecting. Muscles are protecting. Nerves don't like to stretch. And if nerves aren't sliding and gliding and they're restricted, every muscle that they innervate, they're going to tell the muscle, hey, I need you to protect me. Because survival, if you tear a muscle, you can still run away. If you tear a nerve, you're toast, especially if you do some damage to the central. So what takes priority? Central neurodynamics. I need to know, does that dural tube and spine slide and glide, or is there compression in any of those segments? And then once we move and then we look at myotomes, right? Is there a nerve conduction problem? Is the electrical system communicating to the muscles? Because oftentimes weakness is not weakness. It's muscle inhibition because it's not getting full signal. And nerves fatigue very quickly. So we check the myotomes. Okay, cool. Sometimes when we put the neck in flexion extension, it gets worse. There's a neck component to this, right? In the central tube. I test, I don't know how many times, I'll check L4-5 myotomes, and then I see their neck hinges and it's unstable. I put their head in extension and the L4-5 myotome's gone, obliterated. I was like, okay, so we have a central tube. I said, I'll ask people, oh, you're coming in with back issues. Any neck issue? Oh yeah, I've had 20 years of neck pain and I had a car accident 20 years ago. Well, we need to look at that because it's not fixed. Because anytime we change the neck position, it's affecting conduction down below because it's the top part of the tube, right? And all of a sudden we put their neck into a better position, myotomes come back on. Okay, sweet. So we have what's called positional inhibition. Their nervous system's not going to give you power if it doesn't feel safe. It shuts it off because it doesn't want you to add power to a system that can't manage it. Because if we do something bad to the spine, we're in big trouble. So it's like, well, I'll sacrifice the peripheral muscles and joints to save the spine, right? So we have this hierarchy of importance and the nervous system will protect. Like think about, why is our brain encased in this huge, football helmet thing? Because it's a very important supercomputer. Why is the spinal cord encased in bone? Why are all the
Same
vital
with the
organs?
rib cage.
Why are all
Exactly.
the
We've
vital
got
organs?
cages.
Right. We have cages. So obviously the nervous system is going to protect those things. And if there's anything wrong with those very vital pieces of anatomy, it will send pain signals to someplace to say, hey, I need you to find out what's going on, but I'm not going to let you sacrifice. I'm going to divert energy from over here to take care of this very important thing for survival. So there's a hierarchy of importance. The brain cares more about the neck than it cares about a shoulder. If you've got a neck that doesn't move, or there's nerve impingement, the shoulder's going to get abused. But what else supplies the shoulder? C5, C6, 7, 8 for all the lats and pecs and triceps. C7 nerve root causes rotator cuff problems because brain's like, well, I have C5 available and M5-6, but C7 turns off when I look up. So we look at the electrical system. And then if in the history, they're like, I've had past concussion, whiplash, or any kind of collection of injury on one side of the body, I want to look at the cerebellum because the cerebellum controls rate, rhythm, and force and accuracy. So if they've got a collection, I've got right shoulder, right low back, right hip, I'm like, oh, has that always been
and
like
pain
that?
inhibition, right? Yeah.
And pain inhibition. So the brain's like, okay, well, we got one side firing up different than the other. And all of a sudden we do Fukuda tests or we do some cerebellar tests and it's showing there's cerebellar issues. Well, we got different firing rates. And now we're going to have an overuse problem on one side because one side's firing up differently. And then we look at the parts and the pieces. What's optimal, right? We want to see hip rotation, 40 to 50 external, 30, 40 internal. If it's there, great, move on. If not, I want to know, is that soft tissue or is that a capsular restriction? Because those are two different solutions, right? If I have a hip that doesn't rotate, guess what I'm going to rotate more into? Low back. Guess what's designed not to really rotate that much? Low back. They rotate 1 to 3 degrees maximally. And
Yep.
it's not designed to rotate. But the hips and the T-spine are. So you got a T-spine that doesn't rotate, and then you have hips that don't rotate. Guess where all that rotation likes to go into? Oh, the back moves that. Let's just put it into there. Not designed to do that. So now all of a sudden we got chronic low back issues. And you golf. That's a problem. Right? But even with running, we're still rotating, but we gotta be able to force transmit. So we might look at cross cord reflexes. Maybe the slings are off. Maybe the timing's off with the core and the pelvis. And we can do like biofeedback testing and muscle testing to see if it's influence or not. So there's lots of things, but we go through there's an algorithm. I go through the exact same assessment with every single patient, regardless of what the injury is. So I want to know, okay, yes, you've had this surgery, but I want to know what kind of compensations we need to correct while we treat this thing. Or I want to know what's not pulling its weight. Where are you transmitting force into? What are you avoiding? Because all of this will take that energy, take those forces and accumulate it into wherever it moves really well. Whatever the brain can find, it will fire. What it can't find, it will not fire. Okay? If you can't feel it, can't find it, can't fire it. So the brain will avoid it. Because the brain will not waste energy trying to force range of motion into something that doesn't move. It's too hard. It's energy expensive. Oh, I rotate really well over here. I'm just going to do more of this because it's easy.
We're just going to take a quick pause from this conversation to acknowledge our sponsors, and then we'll be right back. The Zelos Podcast is sponsored by Kinetic IQ, where intelligence meets motion. Kinetic IQ brings a biomechanics lab into the palm of your hand, letting you measure movement anytime, anywhere with just an iPad or iPhone. No wearables required. I've been using Kinetic IQ in my own practice, and whether you're screening athletes, optimizing performance, or guiding return to play, it helps practitioners like us save time, capture more objective data, and make instant actionable decisions. So to learn more about how Kinetic IQ is shaping the future of intelligent movement, visit kinetikiq.com. That's KINETIKIQ.com. At the forefront of metabolic elite is Jim Lavelle, internationally recognized clinical pharmacist, a chief science officer at Lifetime, and the co-chair for the American Academy of Anti-Aging Medicine. He's got over 4 decades of experience and has guided Olympic athletes, professional teams, and leading health institutions. You know what makes Metabolic Elite different is their commitment to real results. Like Lipitab, their proprietary solid-state liposomal delivery system. It's a chewable format which enhances absorption like nutrients like BPC 157 and synapses. They're delivered more efficiently in the body, supporting recovery, focus, cognitive health. Their formulas go beyond the basics, solving performance health challenges at the system level. Every product is tested for quality, it's backed by research, it's trusted by athletes and clinicians alike. And you can get 10% off all of Metabolic Elite products by entering the coupon code ZELOS, Z-E-L-O-S. You know,
Yeah.
we've both studied under Eric Cobb with Z Health and Applied Motor Neurology (AMN), and I'm sure there's several others that we've probably been maybe not in the same classroom at the same time, but we've visited these. And so we're very much into the autonomic nervous system, sympathetic, parasympathetic responses, what with the output based on what kind of input we're affording the individual. But then we don't often talk about the thalamus, like the gatekeeper that determines threat as well.
Right.
So I just want to spend a moment talking about thalamic responses and like how do you suss that out? How obviously it's quite easy to see if there is some type of sympathetic or parasympathetic response, but how do you feed up into the thalamus?
So the thalamus is all the information has to go through the thalamus, right?
Right.
And then it's going to decide, is this a threat or this is a non-threat? And somebody who's in a very high sympathetic state, everything's perceived as threat. So now the question is, well, how do I reduce that threshold of them being in this sympathetic state? And I find the more complex somebody is, the more things going on, the more simple it has to be. I go
Breathe.
after breathing. Every single time they're breathing like this. And I'm like, okay, let's just take this down first, because breathing is that bridge between the sympathetic and parasympathetic. Breathing, it is controlled by our emotions, but our emotions can also control our breathing. So when we're happy, our breathing changes. When we're sad, our breathing changes. But if we're conscious and aware of it, because most people aren't even aware of what they're doing. But like, do you ever notice how you're breathing? No. Do you know how many breaths you take in a day? No, I don't. 24,000. You're doing 24,000 shrugs every single day. No wonder your
And
neck
you
is
wonder
so.
why your neck's bugging you. Yes.
Yeah. So I said, well, let's try and change. Let's make them aware of their breathing first. Let's just try and get them out of that. Because if someone's so sympathetically driven, everything's going to push them over that threshold. It does not matter, because getting them to exercise and move and they feel unsafe, I can't do that. Well, it's not helping. Okay, let's go after the first movement that we learned to do, breathing. And we didn't even have to learn to do it. We just screwed it up as we got older. Babies come into this world, they breathe reflexively perfectly, right? But then all of a sudden we sit, we're not moving enough, we have pain, we've got past history that all of a sudden changed our breathing patterns. It's the first movement we learn to do when we come into this world. So oftentimes it's the first movement we need to fix before we do anything else. Because if we don't fix the breathing and we start stacking movements on top of that, well, if you got crappy breathing, those movements are crappy. We're stacking dysfunction on top of dysfunction. So let's go after that first, because it shifts the nervous system. It changes our chemistry. It allows biology to change. So it reduces inflammation and it builds that connection and that trust. Oh, okay, I feel safer now. Great. Now let's move the shoulder. Now, I can move the ankle now. Thank you. Right. But it just created a shift. I don't think we need to, the neurology is more complex to understand it than to apply. I think the principles that we need are more simple. So yes, the brain is an amazing thing, and we know very little about it, and we're knowing a little bit more. But if we understand those underlying core things it's looking for from a survival perspective, and what the person in front of us is missing, we can make that shift right away. We can use tapping, we can use vibration, we can use all that, right? We know how that affects the thalamus. It downregulates the amygdala when we do EFT, emotional tapping. The functional MRIs have proven that. When we do a couple minutes of tapping, that vibration creates a calming effect. It discharges the sympathetic electrical system. And all of a sudden, things relax. Okay, great. I've moved you away from this threshold of sympathetic. Now I got a little wiggle room to add a little bit more stress to your body. And then if we jump over that threshold, I'll just bring you back down. But it's making people aware. Like the first type of breathing we make people do is just breath awareness. How are you breathing and where are you breathing into? And for most people, it's just like, let's just do some, 4 seconds inhale, 8 seconds exhale. Let's just double that exhale to shift you into parasympathetic. And then once we have that, now we can stack on intentional hyperventilations. We can do Sufi breathing techniques. We can do breathing behind the iron shield and all that stuff. But that's sympathetics. But that's intentional, right? We can manipulate our breathing to either improve performance, but we can also use it to downregulate. But it's being aware of what state you're in and what state do I need to be in order to manipulate my breathing. So if I'm aware of my breathing, I can take control of it because it's conscious and it's unconscious. But if we're not realizing what we're doing, then we do not have control of our nervous system.
So fantastic. I mean, there's an overarching repeated theme here of what you've been saying, which is the more complex, the more we go back to basics. No
Back to
matter,
basics. Yep.
whatever we're talking about, the person, the environment, and everything else, if you're feeling, even if you've got the paralysis through analysis, the surefire way of getting out of that, let's just start with the basics.
Yep.
Can this occur? Can that occur?
Yep.
What's different? What's missing? Those type of things. So I got this. I'm always curious about, like you said it yourself, coming out of the gate at school, they gave you, well, enough to be dangerous, right? But what you do after that really takes a lot of the danger away, as far as I'm concerned. So what's one belief about rehabilitation that you held early in your career that you've like completely abandoned?
Yeah. If I gather enough tools, I can fix everybody. And that was if I have this tool, it's going to solve all my problems and I can help more people. Oh, that didn't work. On to the next tool. If I gather enough tools, I'm going to be amazing at this. I got really good with the tools. Again, I did not have the deeper understanding of which tool to use at the right time for the right person for the right purpose. And that came with structure and systems. That came with a deeper understanding of first principles and a framework to build all this knowledge on top of. So now, because of that first level of understanding, I can go learn something, but I can integrate it so much quicker because I have something to build it into. But that first belief of, I'm just going to go out and learn as many things. And I encourage new clinicians, go out and learn as many tools as possible. But you need a toolbox and you need a blueprint on how to use. What are you building? If you do not have a blueprint, then you don't know if you're building a house or you're building a car or you're building a shed. I don't know. If you don't have a toolbox to know which tool to pull out at the right time, well, you got this amazing hammer called dry needling. Everything's going to look like a nail, right? And so many people get fixed on a tool. You get so good at a tool that you find every reason to use this tool. I'm like, no, that's not clinical decision making. That's not being a clinician. That's a technician. You're just applying a tool for the sake of applying a tool. That's not clinical reasoning. Oh, well, I'm going to use my dry needling to release this hamstring muscle. Why is that hamstring muscle switched on in the first place? Is it nerve tension? Is it?
And honestly, I'm so glad you brought that up because it's been leading down to where I want to go next, which is the whole concept of weak versus strong, inhibited versus facilitated, however you want to say it. We at least in the fitness industry, have been drummed through the fact that this muscle is weak. But like you say, it's the nervous system that controls everything. So the nervous system has a priority of its own survival, and it's creating strategies based on the experiences of that individual and how it's navigating, almost like a driver's app, to go from one place to the other. And it's a long road journey, and things happen along the way. And the next thing you know, that initial way of getting there has been altered to the next best way of getting there. And that's life in general. So that means that muscles are not necessarily weak or strong. They have been either downregulated or given more authority and more excitation. So I guess, have we become more tissue centric in the way in which we think, and should we start thinking more along the lines of what I just described?
We need to do both. So let's go back to the muscle inhibition. So you test a glute, right? You get them on the table and your glute maximus is inhibited. Okay, well, it's weak. I don't know why, but you also see that, well, you got a little bit of an anterior pelvic tilt and that quad and hip flexors are toned up. Well, what happens if I just release those hip flexors a little bit or change the input? All of a sudden glute switches back on. Well, shit, it wasn't a weak glute. It was inhibition, simply because the pelvis wasn't in the right position. Nervous system wasn't giving you access to it. So we can't sit there and be like, well, we just need to keep muscling through this. If you have a hip that does not extend because of a capsular restriction, you cannot exercise your way out of that. You need to do manual therapy. You need to do the joint glides to allow the joint to slide and glide into a better position so the glutes can actually do their job in extension. But if the hip's stuck in flexion and then the hip can never get into neutral or extension, glutes, you're never going to get access to that. So what do? Go into our back, right? So we can't, because I don't want people to say, oh, we never have to do foam rolling and manual therapy. And so like those are inputs. It's just making sure we're applying the right input at the right place to create the result that we want. Because movement and muscle testing is output. Outputs is, it's a feedback loop for effectiveness. If we applied the right input, stuff switches on, muscles turn back on. If we didn't apply the right input, nothing changes. So go do something else. But you can't sit there and be like, well, your glutes aren't firing up. Let's just do glute bridges. But now you've got tissue, tight tissue on the front, fighting tissue on the back. And now you're creating fatigue and exhaustion. Now you just taught those glutes to stay toned. Well, then they're going to come in with piriformis syndrome because the glutes can't let go, right? Because we haven't taken care of the tissue, the tightness on the front, and it's causing pain in the back.
I love it. Yeah. Posture's an output, movements an output, pain or threat response is an output, but it's the input that we really need to explore, assessing and reassessing and continuously. Okay. I'm all over the place in my head right now. And there's something that happened just this past week. I'm watching a colleague who I respect in the field, and he's on this talk with somebody else talking about trainers, coaches, and that we shouldn't be concerned with taking away pain, which, okay, that's fine if we want to call that outside of our scope of practice, but we shouldn't also be developing or creating an environment that encourages pain at the same time. So I'm a little bit torn up with that statement because we have a disconnect, in my opinion, between the work that you're doing and the average trainer that's in the gym. There is like, okay, I'll get you here. And then the trainer will say, okay, we're just going to do a program, not necessarily take into consideration what you have just provided the body for. We're just going to do the same traditional lifts. And if there's imbalances, whatever, we're just going to strength train through it. And if something pops up, you'll just send them back to you. Do, are, are you in this insane cycle as much as I am?
No.
Well, that's good. That's for sure.
No, I don't think so. I mean, what we do at our clinic, it seems like common sense, but then of course we leave and we listen to other people. I'm like, how do you not know this? But this is where pain. Okay. Are we talking about pain? Or are we talking about discomfort? Right. Because
yeah.
Right.
That's quite different.
Those are two different things. If I sit here on a machine and do leg extensions and my quads are burning, is it painful? Yes. Is it discomfort? I'm going to say it's more discomfort because you got lactic acid building up and hydrogen ions and it's creating that burn. But that's muscle, right? And that goes away pretty quickly. But if I'm doing squats and I feel a pinch in my low back or I'm pinching my knee in the joint, that's a problem, right? Those are signals that we do not want to play around with. And pain is a signal to pay attention, but pain is also a signal to do something different. As we sit here, right? You probably notice me, I kind of wiggle around a bit because my back gets tight. Well, that signal that my nervous system's saying, hey, we're overloading the tissues a little bit. Maybe we move around to get the blood flow. And all of a sudden the pain goes away. So that pain is a signal saying, hey, we need to change something. We're sitting here too long. So I'm going to create discomfort, right? And that discomfort is a signal for me to do something different. It's an input. It's information. It's saying, let's do something different, change position, blah, blah, blah. If pain is lingering around after an exercise and it's in specific joints, tendons, excessive tone or tightness, then we got to start questioning, well, why is that there? What are we doing in the movement? Because we can't keep training through that because one, we'll either keep overloading it until it fails, right? Then we cause macro trauma, or the body shifts away from it and loads differently. And then all of a sudden we cause a problem someplace else. So we need to understand the difference between discomfort and pain. And what are those? What kind of sensations are those? So making the athletes aware of, there's normal discomfort with training. Yep, muscles burn. That's okay. But I also don't want sharp. I don't want electrical. I don't want stabbing. Those are bigger signals. Those are bigger signals to
Certainly.
pay attention.
I guess what
So
I'm saying is like we both have framework. You've got a certain methodology. I've got a framework that
yeah,
takes these into consideration, no matter where you are on the spectrum
yeah,
of like rehabilitation and optimal performance, and they carry over the entire way, so that now the exercises that are being selected in the strength environment, in the weight room, and so on, should be dictated by the nervous system. It should be dictated by the structural positioning. It should be dictated by that more so than your repetition max test or what the strength conditioning textbooks are suggesting as a program. I guess that's what I'm getting at, Tom, is like there seems to be that all this work and then we drop it off and we enter the weight room. At least that's what I'm seeing. And I feel like the work that you're doing right now and the framework that's been developed needs to continually carry on into guiding individuals along the course that you've been doing, but also with resistance training, foam rolling, mobility drills on the playing fields and so on. Do you know what I'm getting
yeah,
at?
yeah. So I'll give you an example, and I can talk about this. Mitchell's fine with it. So I've had the privilege to work with Mitchell Hooper, World's Strongest Man, and we actually just went to World's Strongest Man, and he won again this year. And the first time he came and saw me back in 23 after he won the first time, he's like, "Hey, I'm told I need to come and see you." I'm like, "Sweet, come on in," because he's from Barrie. And I was like, "What's going on?" He's like, "Well, I always have this kind of right knee, right groin, right low back issue." I said, "Okay, cool. When does that get worse?" "Squatting." I said, "Okay." I take him through, look at his posture. He's had some concussions. So we looked at his convergence on his left eye is a little bit off. His Sharpen Romberg, he falls a little bit to the left. I'm like, okay, that's interesting. And then the one test that we looked at, I had him squat. I said, "You notice you shift to the right?" He's like, "Yeah, I don't know why." I said, "Okay." I said, "Stand on one leg for me." He stands on his right leg, 10 seconds, eyes closed, no problem. Stands on his left leg, falls in 2 seconds. Well, that's a problem.
Especially when you're lifting so much weight.
Right. So the first time I saw him, this is the first treatment, first assessment. We did some testing. Obviously, he's very stiff. That's fine. Like that's going to be his structure. I'm not going to get him to do yoga. But one of the other interesting things we found is I was testing his glutes. And as soon as I dropped his head into extension, his both glutes shut off. I was like, "You're doing all squats with low back and quads." Because what are you doing with the neck in the squat position? You're dropping.
Extending.
Right. So for some reason, it's creating inhibition down into his glutes. I said, okay. So we did a little bit of rib mobility, got him in the gym, did a little bit of dural decompression, L-DOA. What was the first thing? We did some eye exercises to the left to get his convergence going. We did a little bit of rolling patterns. And then I gave him a bird dog, right? Give him a little bird dog exercise with the neck around to get him into neck retraction, right? And just do some hip extension. And then the last exercise I said, okay, before you squat tomorrow, you're going to do these exercises, and then you're going to put a band around the head to teach the neck to stack better. And then immediately he's like, "Oh, I can squat so deep when I do this." Awesome. The next day he texted me, "I just PR'd back squat 800 pounds for 4 reps. No pain."
Boom.
That's amazing. But what did I do? I did rehab, but I gave him what he needed. How did rehab exercises unlock his performance? Because I just applied he's already the world's strongest man. I'm not going to have him sit there and do more squats. He knows how to do that. I had to balance out his system so that he started to shift weight onto that left side, get his glutes firing up, get his neck into a better position, and unlock potential. That's all I did. I removed the brakes. Now, on the other end, we have an 85-year-old lady. She likes to come and see us. She doesn't like to go to the other rehab facilities because that's for old people. And she's got balance issues. She's all kyphotic, and she's worried about falling. What do we give her? Deadlifts. We give her agility ladder, and we will get her to walk on the balance beam. You could say those are high performance. No, they're not. They're rehab. But I gave her what she needed, and all of a sudden her balance gets better. She's got less fear of falling, and she's stronger. So
Oh, thank you.
it depends on the person in front of us. But this is why the assessment is so important. I could look
Huge.
at Mitch and be like, well, all right, we need to do strength stuff. No, I don't. I needed him to do some very basic things that his brain could not figure out how to do. I just need to change the inputs in his body so that his nervous system felt safe to shift over to that left side to squat more symmetrically. I gave him back his glutes and his neck position because when his neck was coming up, nervous system said, I don't like this. I'm just going to reduce power. And that power reduction was ending up into the right side of his body. Right? So we have to appreciate pain. Can we get away from pain? No. But we also have to know that pain is inhibitory. It's not high performance. Pain is a stop signal, not a go. And if you keep ignoring that over time, it will put the hard brakes on by letting something is going to go. It will go. Now, here, I'll tell you another quick one. So Nathan Goldtree, and you can see the video on YouTube. He reached out to me. He blew off both patella tendons a year ago doing a 440-pound log press. So you can go onto YouTube, and he cleans it, and he dips into his knees. Both patella tendons pop, and the log comes crashing down on ruptured spleen, punctured lung. Oh, yeah. You just see. Now, he had knee pain going into this. He's been dealing with it for years. So guess what? He dipped into that 440-pound log into lumbar extension, nervous system let go, shut off both legs, and tore both patella tendons off. Now, a year later, he came to me. He's like, I've had knee pain for 9 out of 10. He's like, I can deadlift 800 pounds. I cannot go downstairs. I cannot load into this. I was like, fly out and see me for 3 days. First day, he's got foot weakness. Anytime I tested his foot with his glutes, shut off the glutes and the hamstrings. His hamstrings weren't firing up. Glutes aren't firing up. Core, all kinds of neurological stuff. Guess what was working pretty good? His quads. The only muscle group that was actually doing anything right now is his quads, but he kept getting patellofemoral compression. So after the first day, we decompressed, gave him some mobility stuff, balance stuff. Day 2, I got him 1 out of 10 knee pain, and he could squat simply by his feet connected with his hamstrings and his core and his glutes. And we turned on everything else around the knees. And then the third day, we got him back on the squat bar. I got him kettlebell swinging and front squatting. He's like, this is amazing. He's like, I have no pain. It's like, awesome. Because we got everything around the knees to support the knees. But had I not done that thorough assessment, everyone's banging on the knees. I'm like, it's not the knees. The knees, structurally, the knees were great.
The knee's the solution, if anything.
Right. He's got great mobility. For a big guy, he has amazing mobility. And he's an athlete. Things weren't firing up to support the knees. So guess what he was doing? Brain's like, I can feel my quads. I'm just going to keep using quads for everything. Feet weren't working. Hamstrings weren't working. Glutes weren't working. Spine, deeper core was not supporting his spine. So, of course, when he got that log into extension, compressed the system, pinched nerves, shut off the quads.
Oh, man. Tom, I love it. I love these stories. And I'm sure you've got a whole drawer full that you could just pull out and share more. But I don't, I've taken so much of your time already, and I feel like volume 2 is somewhere in the makings. But tell you what, if people want to learn about advanced movement therapy or any work that you're doing, anything that you have out there in regards to research, blogs, books, website, and all that, where can we go?
So amtcertified.ca, that's our education platform. You can look at the certification. We've got some smaller courses in there, running. We've got breathing. We've got a couple of mini courses in there that we're putting together. SAM scans in there, self-awareness movement scan. This is something that I teach to coaches, to teach the athletes on how to create greater self-awareness through self-assessment, looking at 3 cerebellar tests and global movements, and then creating symmetry. It saves a lot of time on the back end of like what rehab exercises or corrective exercises. But again, if we have a level of symmetry in our body, when we go do something symmetrical, there's a less likelihood of something getting overused. So we want to make sure that we can balance on both legs. We can squat, we can bend forward, touch our toes. Like they're very basic movements, and it takes less than 3 minutes to do. And if we can teach our athletes to, which is what I do, now they have a tool for themselves. You're like, hey, did you scan? Oh, you know what? Rotation's off. Is it your T-spine or is it your hips? Oh, it's my hip. Go put the band on there. What do you feel with the hip? I feel a pinch. Probably a joint problem. Go put the band on there. Do some clamps, some side steps, recheck. Oh, that's clean. Great. Let's go train. Right? Now we don't have to sit there and foam roll everything and mob everything and activate everything. You need 3 exercises, but you need 1 scan, and it removes a lot of the guesswork. So lots of education there. Instagram, swales.tom. Lots of longer format on Tommy Swales on YouTube. But you can find me on all the LinkedIn, all kinds of content, free content there. And then, of course, my podcast, Staying Relevant, which you've been on, which was a great episode, by the way.
I had so much fun. And this is volume 2. So for the listening audience, definitely head over to Tom's Strictly Relevant. Strictly Relevant?
Staying Relevant, the future of rehab.
Staying Relevant, sorry. All right. Man, are you going to be presenting anywhere? Like, when are our paths going to cross?
I'm at SWATA, Southwestern Athletic Trainers Association. I'm teaching 2 workshops there. I'm doing my neuro hacks on how to move better and reduce pain in 60 seconds or less using some neurological stuff. And then I'm also teaching a Beyond the Shoulder, basically how to assess neck, nerves, everything around the shoulder before we go after the shoulder. And then I'm at Camp Fit Pro in August doing my neuro hacks again.
I think I'm just going to come to Ontario and hang out in your place for a few days. That's all there is to it. Man, thank you so much. I appreciate you.
I appreciate you too. Thanks, Rocky.
So we're going to put a thumbtack in that one and maybe revisit another conversation down the line, because there's so much more to unfold with Tom. I can't thank him enough for coming on. Remember, we've got one more functional training summit with Perform Better. That's going to be in August 20th to the 22nd in Providence, Rhode Island. If you haven't been to one, sign up now. And if you have been to them, you're probably already registered. Remember, Tuesday, July 28th, it's going to be noon Eastern, 9 a.m. Pacific, a free webinar between Bobby Aldridge and myself through Perform Better called Metrics and Mobility, a practical framework for assessing and tracking mobility. Be sure to check it out. You can go to my website, Rocky Snyder, or performbetter.com for more information and review this podcast. I'd love to hear your thoughts and who else you'd like to see on the show. And you can do that on Instagram at Rocky_Snyder. And have yourself a great week. Here's one more listen to our amazing sponsors. Remember to check out metabolicelite.co. Check out all the products they have on their website. Synapsin Pro is something I've been using to help stay focused without having to over-caffeinate myself. It keeps me in the zone so I can just really hone in on the things I need to achieve without feeling like, man, I gotta reach for an energy drink every 5 minutes. metabolicelite.co. And don't forget, Kinetic IQ. They've got markerless motion capture for morons like me. I can use their product with my iPhone or my iPad. I can look at posture analysis, movement analysis of any exercise, gait analysis. It gives me everything I could possibly want when tracking people's movements. So, check out kinetikiq.com.